Hi, everyone, and welcome to another Autumn 2020 Michael Davis Lecture. The Center for Health Administration Studies has always advocated for innovative, evolving technologies and methodologies to disseminate and champion health research and services policy. With many crises intersecting in the United States and across the globe in 2020, CHAZ has a goal to make the latest health and research topics accessible to as many people as possible. In a moment, I'll pass the mic to CHAZ co-director and SSA professor Harold Pollack to offer brief opening remarks and to provide an introduction of today's presenter, University of South Carolina associate professor and SSA PhD alumnus, Christina Andrews. To keep continuity and to allow the presenter to focus on her presentation today, we'll be fielding questions in the Q&A panel at the end of the slideshow. The chat feature has been disabled. I can address raised hands in the Q&A panel as well. If you have questions, please type the questions in the Q&A. The PowerPoint will be available, and a recording of this presentation will be available on the CHAZ YouTube channel following today's presentation. And now I'll be recording the presentation and pass the mic to Harold Pollack.
Thanks so much, Keith. I should say that I've questioned Christina, and she tells me that her mom is not on the Zoom call, so I'm not going to give every possible thing I could say that's nice about her in the intro, but I'll say a few things. One is, as Keith mentioned, it's wonderful to have one of our own back. Dr. Andrews is one of our real amazing people among many who's been through our PhD program. Christina was actually my TA in SSA 456 years ago, and one of, just among other things, is a wonderful teacher. And I remember when the class ended, I got a note from 12 different students saying how much they thought she was just a fantastic teacher, and how grateful they were for the work that she had done helping them in my class. And you know, that's really quite unusual for, and speaks highly of her. So Christina has been, she got her doctorate in 2012, and she's really emerged, along with colleagues, colleague Grogan, Amanda Abraham, and others, has really emerged as a national leader in understanding questions at the interface of the opioid epidemic and Medicaid. And Medicaid is such a key tool for dealing with this epidemic, and really, she is one of the go-to people in understanding what are we doing well and what are we doing poorly in using that tool. As Keith mentioned, she's now associate professor of public health at the Arnold School of Public Health at the University of South Carolina. And I won't go through her CV because it's, I don't want to make anybody feel bad to see the length and quality of what's there, but I'll just say I'm really looking forward to hearing what she has to say. So, Dr. Andrews.
Thank you so much, Harold. I appreciate that introduction. So, and thank you for the opportunity to be here today and to share some of my work with all of you. I'm going to talk with you about a project that I've been working on with several colleagues, Colleen Grogan, also at the University of Chicago, Amanda Abraham at the University of Georgia, and two very talented doctoral students, Melissa Westlake and Samantha Harris. And this research is focused on looking at coverage for opioid use disorder treatment within the nation's well over 200 Medicare managed care plans. Unfortunately, my screen is not moving.
Christina, can you try, restarting?
Okay.
What is a seminar without Zoom hijinks? It's good that we got that at 12:36.
Can you see it now, or?
It's you right now. We're looking at you right now.
Okay. All right. Let's give it a shot.
Excellent room raider, by the way, background.
How is that?
We're now looking at Urban Institute presentation. It looks like
It's your Windows Explorer.
Yeah. Yeah, I think you need to unshare again.
I apologize. I'm screen sharing this right now.
Yes.
Yes.
Can
We
you
can
see
see
it
you.
now?
No, we're seeing the same thing that you were showing.
Okay, I'm sorry. I'm just going to close out of
Share
everything.
your screen. Yeah.
That's okay. Like Harold said, there's always a Zoom glitch.
Okay.
When
Keeps
I
it
was giving my
exciting.
Can you
job
see
talk
it now?
no, same thing. When I was giving my job talk at SSA, I unplugged the computer that had my PowerPoint on it in the middle of my presentation, and no one had the password to the computer, and I had to do the entire job talk with chalk on the chalkboard. So you're way ahead of me.
Okay. How about now?
Yes.
There you go.
Yay.
Now we're looking at a fentanyl, the chart of the trend line in overdose deaths.
Wonderful. There we go.
Perfect.
I
Good.
apologize, everybody. Thanks for bearing with me. So I know it will come to no surprise to many people on this call that we are in the midst of a pretty significant epidemic of opioid-related overdose and mortality. And unfortunately, the COVID-19 pandemic has only served to exacerbate this epidemic. There's reports coming out of the states right now that indicate that upwards of 30% increase in overdoses related to opioids over the same time last year. And you know, while we can speculate about many of the reasons that that may be the case, the reality is that it's more important than ever that we have access available to evidence-based quality treatment for opioid use disorder, including medications. So we know that evidence shows that treatment, particularly treatment that includes medication, one of our 3 FDA-approved medications, extended release naltrexone, methadone, and buprenorphine, reduce the risk of relapse, overdose, and death from opioid misuse. But you know, these clinically recommended treatments still are not received by many people who need them. As recently as 2015, estimates suggest that fewer than 1/3 of Americans with opioid use disorder received any FDA-approved medication for treatment of their condition, and even a smaller proportion received any kind of concurrent psychotherapy for opioid use disorder. So why focus on Medicaid? The reason for that is simple, and it is that Medicaid is the largest payer of opioid use disorder treatment in the United States. Right now, Medicaid pays for an estimated 37% of all opioid use disorder treatment services that are rendered in the United States, and they provide coverage for more than half of low-income Americans, so people who may be particularly challenged in terms of accessing treatment and have limited ability to pay for those services out of pocket. And because of this important role that Medicaid plays in financing treatment, it's really widely come to be acknowledged as a key policy lever that the government and stakeholders have available to expand access to opioid use disorder treatment. So because Medicaid is so important in this regard, there's been quite a few major efforts over the past several years to try to characterize coverage for opioid use disorder treatment in Medicaid, and work by a group that I've participated in, as well as Harold Pollack and Colleen Bergen, was conducted as part of the National Drug Abuse Treatment System Survey. A number of other really important efforts in this regard. What we found through our research, conducting a survey of all Medicaid programs in the United States regarding their coverage, was that there was a lot of variation in terms of the treatment services that they covered, and that very few of these states provided coverage for all of the treatment services that were recommended by the American Society of Addiction Medicine. We found some of the same issues with regard to medications, which you can see here. These states in dark blue in 2017 were not providing coverage for all of the FDA-approved medications for opioid use disorder. And in this case, these states in the dark blue at that time were not providing coverage for methadone. I know a number of them have done so since then, and now will all be required to do so under the Support Act beginning this month. So while efforts like these have been really important, the information that we glean about coverage by asking states about the coverage within their state plan really only tells us something about coverage for people who participate in fee-for-service Medicaid programs. But the reality is that the vast majority of people enrolled in Medicaid in the United States now participate in a managed care plan. And the reality is that we do not at this time have a lot of information about the coverage for opioid use disorder treatment within these Medicaid managed care plans. The reason that I think that is the case is because it's incredibly difficult to get information about managed care coverage for opioid use disorder treatment because you've got to look across all of the programs in the US, and there are many of them. So the question that really motivated the work that I'm going to talk to you about in part today is, can we assume that the opioid use disorder treatment benefits in these managed care plans are consistent with the benefits specified in the state Medicaid fee-for-service side? Fee-for-service side being the coverage data that we have available right now. There are certainly reasons to believe that they might not be the same. We know that MCO plans are subject only to the coverage and utilization requirements that the state requires them the services the state requires them to cover in their contracts with the state Medicaid programs. And there's not a particular policy that bars MCO plans from denying coverage for particular OUD treatment services. The other thing I want to get into today is to take a look at some of the prior authorization policies that these Medicaid managed care plans are using. We know that prior authorization policies for opioid use disorder medications have been identified as a major barrier to treatment access. For example, in the Medicaid population, prior authorization has been linked both to lower rates of treatment receipt as well as increased use of acute care for opioid-related conditions like ED visits. We've also found that these prior authorization policies can also be linked to the availability of opioid use disorder medications. For example, in work we did as part of the National Drug Abuse Treatment System survey, we found that substance use disorder treatment programs that were located in states in which the Medicaid program required prior authorization for buprenorphine had 50% lower odds of offering that medication. So in terms of the three questions that I want to take a look at today with all of you, the first is, does coverage for opioid use disorder treatment differ across the Medicaid fee-for-service and MCO plans? And then to look a little bit more closely at this issue of prior authorization. So to what extent are Medicaid MCO plans requiring prior authorization for reimbursement of opioid use disorder treatment? And then to try to look at whether there are differences in the use of prior authorization across plans that are located in different geographic regions, as well as on the basis of their ownership status. So by that I mean whether these plans are for-profit or nonprofit. So to conduct this particular research, we've drawn from two main data sources. To gather information about the fee-for-service coverage, I employed a survey of all state Medicaid agencies with the assistance of the University of Chicago Survey Lab. We conducted this data in 2017 and had a response rate of 92%. We asked them about their coverage for all of the treatment services and opioid use disorder medications that were recommended by the Addiction Society, American Society for Addiction Medicine. To gather information about the MCO plans, we went through a process of data abstraction from all of the publicly available documentation regarding from these MCO plans. So we identified 38 states as having active Medicaid MCO plans in operation. And we found 264 plans within those 38 states. If we found that a particular state had multiple enrollee-specific plans, we picked the adult standard plan with the largest enrollment for inclusion in this particular study and focused only on comprehensive MCOs. So among those 264 plans, we pulled all of their publicly available documentation that included member handbooks, provider manuals, drug formularies, PDLs, and reviewed these documents to get information about their coverage and use and utilization requirements like prior authorization. If we found that a particular plan carved out their opioid use disorder treatment to either behavioral health organization, regional behavioral health authority, or to fee-for-service, then we sort of went down that rabbit hole, gathered all of the publicly available documentation from that carve-out entity and repeated the process until we really had a full picture of coverage for opioid use disorder treatment within these particular plans. So it's difficult to overstate what an incredibly time-intensive process it was to gather all of this information. I believe that there was one particular plan where we had to review 13 different documents in order to obtain a full picture of coverage for opioid use disorder treatment within that particular plan. And I'm very grateful to Melissa Westlake and Samantha Harris for the incredible work they did in combing through these plans for us. I do want to just provide an example, from one particular plan in California, just to give you a sense of how cumbersome it was to gather this information. It could take upwards of 2 to 3 hours to collect this information for each individual plan. And I certainly won't go through all of these steps with you, but provide this here just to give you a sense of how involved collecting this data was. So this here is a list of all of the specific treatment services and medications that we included, and an indication of whether we collected data on that particular service or medication in our fee-for-service survey or the MCO abstraction project. And X actually means that we do have data from that wave, just to be clear on that. And while I know this particular presentation today is focused on treatment for opioid use disorder, I also include the alcohol use disorder medications as well, because I think it provides an interesting comparison. And I'll talk more about that a little bit later. So we also gathered information about MCO plan ownership. Particularly, we determined whether each plan was freestanding or owned by a larger parent organization, and then tracked down the tax status of that parent organization using the IRS tax exempt database. And we cross-validated those findings against the Center for Medicare and Medicaid Services state Medicaid managed care profiles, which typically provide information about the profit status of the different MCO plans that are in operation in each state. And we coded these plans affirmatively as for-profit if we found no evidence of a tax exempt status and or an indication of for-profit status in the CMS profiles. So the data analysis is really simple, and I also want to mention that this is still preliminary work in the process of analyzing these data. So for this particular study here, we compared the opioid use disorder treatment benefits in each plan to the benefits that were offered on the state fee-for-service in that plan state. to try to identify discrepancies in benefits between fee-for-service and MCO plans. And then to look at prior authorization, we calculated some basic descriptive statistics for use of prior auth across each of the OUD treatment services and medications, and completed some bivariate comparisons to look at differences across census region and profit status. So a few study limitations that I want to mention. A small proportion of the MCOs we reviewed didn't indicate whether some of the particular treatment services and medications were covered, so that's sort of a gap in our knowledge. Another potential caveat is that we compare fee-for-service data that were collected in 2017 to MCO plan data from calendar year 2018. So it is possible that fee-for-service benefits may have changed during that period. Another issue is that we weren't able to look at variation in coverage and prior authorization policies within medications. So for example, buprenorphine has a number of different formulations. We were not able to look at all of those individually given the already large scope of our data abstraction effort. So for example, in the case of prior authorization policies, we only code that affirmatively if they require prior authorization for all formulations of a particular drug. And then finally, of course, these data are cross-sectional, and so there are limits to, what we can understand, from these data given that. So in terms of some of the data itself, this particular figure is a comparison of opioid use disorder treatment services covered by Medicaid fee-for-service and MCO plans. And so what you can see here is that the bars in dark blue represent the number of plans where both the MCO plan and the fee-for-service in that state both covered the service. In all of the other cases, that was not the case. So you can see that there was broad coverage for outpatients and inpatient services, but less consistent coverage for some of the other services, particularly residential, intensive outpatient, and methadone maintenance services. In some cases, the plans did not specify whether or not they covered that particular service, which is, I think, problematic from the perspective of individuals who may be trying to choose a plan that will meet their healthcare needs and not having the information that they need to do those in the documentation that's available. We see a similar pattern on the medication side. Lot of MCO plans covering buprenorphine in addition to fee-for-service doing the same in their state. But some gaps, and particularly in the case of injectable naltrexone, we identified about 100 plans that basically did not report coverage for injectable naltrexone in their formulary, although their state Medicaid fee-for-service plan did cover it. So how many people are we talking about? This figure here shows the estimated number of Medicaid enrollees without access to selected OUD treatment medications. 2 million with buprenorphine, an estimated 9 million Medicaid enrollees who did not have coverage to methadone, and about 13 million without access to injectable naltrexone coverage. This is taken by summing the enrollments for the plans that indicated that they did not provide coverage for these medications. So this is not a small number of people who are potentially affected by these policies. So just to give you a couple examples from the data, one of the largest Medicaid MCOs in the country that's located in a large state in the Northeast, within their state fee-for-service plan, which is what most of the policy attention is focused on, provide coverage for all of the major ASAM recommended treatment services and medications. But within the MCO plan, the enrollees lack coverage to intensive outpatient, recovery support services, as well as injectable naltrexone and buprenorphine. And another example, the largest Medicaid MCO plan in one rapidly growing Western state. This particular plan covers about 40% of all enrollees in the state. Again, the state fee-for-service coverage is excellent, covering all of the major treatment services and medications. But a Medicaid enrollee in this plan with an opioid use disorder would lack coverage to residential services, recovery support, as well as all of the 3 major FDA-approved medications for opioid use disorder. So, you know, I think there is a sense that the Support Act, which was passed in 2018, you know, would require all state Medicaid programs to cover all of these medications, buprenorphine, naltrexone, and methadone, and that it has in fact required all state Medicaid plans to do so from October 2020 through September 2025. But this language does not explicitly mandate that states require MCOs to comply. And right now, I don't know if we have a lot of information about how both states as well as the MCO plans are reacting to this particular legislation. So now I want to turn to prior authorization. What are the states, what are the MCO plans doing in that regard? And what we find is that there is a substantial degree of use of prior authorization policies for opioid use disorder treatment. And this service data really applies to all substance use disorder treatment services. You can see very high rates of use of prior authorization across plans for more intensive services that tend to be more expensive, like inpatient, hospital, residential, as well as intensive outpatient services. And you can also see high rates of prior authorization for these opioid use disorder medications. You can see rates of prior authorization for the alcohol use disorder medications are very low in comparison. Buprenorphine in particular has over half of these MCO plans reported requiring prior authorization for all formulations of buprenorphine as well as for methadone maintenance. So given some of the concerns about prior authorization serving as a barrier to access to these medications, I think this is pretty significant. So we also looked at how the use of these prior authorizations within MCO plans differed by the geographic region in which the plan is located. You can see some differences here with perhaps less use of prior authorization among plans that are located in the West. But I think what's more interesting here is the pattern that you see with regard to medications, and in particular where there's a very high proportion of Medicaid MCO plans located in the southern region of the United States that are requiring prior authorization for these plans. You know, in particular, the Northeast and the Midwest showing significantly lower rates. But at the same time, looking at those alcohol use disorder medications, you see more prior authorization in the southern plans in the southern states on that side as well, but certainly not to the same degree. We also looked at differences in the use of prior authorization by profit status. And again, you can see that for-profits were slightly more likely to require prior authorization for these treatment services for opioid use disorder. But again, we see more significant differences with these medications, with for-profits more likely to require prior authorization for buprenorphine and both forms of methadone. Just something that I thought worth mentioning, it certainly wasn't part of our initial analysis, but we also found that there were significant differences in use of prior authorization based on a loose proxy of the political leanings of the state in which the plan was located. This particular figure shows the percentage of Medicaid MCO plans requiring prior auths by the 2016 election outcome. Red MCO plans that were located in red states, as you can see, were significantly more likely to require prior authorization. Of course, I'm not suggesting any kind of causal relationship here, as of course we are looking at cross-sectional data here. So just some preliminary conclusions from our work. The state's fee-for-service benefits for opioid use disorder treatment probably are not a great proxy for the benefits that are provided to the 50 million enrollees in our Medicaid managed care programs. We found that these MCO plans were particularly likely to deviate from fee-for-service and benefits from more expensive services and medications like residential treatment and extended release naltrexone. I think that the state contractual agreements with the MCOs are probably pretty important in terms of defining the coverage that MCO plans provide. And 20 of the plans with the greatest deviation from fee-for-service are concentrated in the same 5 states. So we also found significant evidence of variation in coverage across these services and medications. And the MCO plan that an enrollee ends up in can have really big implications for the quality of coverage that they receive. And given that about half of Medicaid MCO enrollees are auto-assigned into a plan, meaning that they don't make an active choice for the plan that they enter, and they're just assigned one by the state Medicaid program. There can be a sort of random element to the coverage that one enrollee may receive as opposed to another. So in the midst of an epidemic, I think that this is an issue that warrants attention, and I think our findings suggest that some of the state level changes and some of the work done through the Support Act, while very much moving us in the right direction, might not be enough to fully close some of the coverage gaps in Medicaid that still remain. So on the prior authorization side, we found that within Medicaid MCOs, prior auths continue to be very, very common. Not surprisingly, more expensive services are more likely to require prior authorization. The medications are far more likely to require prior authorization when they are for opioid use disorder rather than alcohol use disorder. While it sort of goes beyond the scope of this talk to get into why that might be, it certainly may be due at least initially to concerns about higher risk and diversion of these medications. We certainly found evidence of heavy use of prior authorizations within plans in the southern region of the country, as well as in for-profit plans. So in terms of some next steps, I'm very interested in a comparison of prior authorization fee-for-service versus the MCO plans, as well as doing a deeper examination of some of the differences in the MCO plan coverage across ownership status. We are planning a future study to examine how MCO plan coverage is linked to opioid use disorder treatment outcomes using claims data, and are also working towards a closer look at how states are regulating these MCO plans, both in terms of their contractual agreements with the plans, as well as some of the legislative change. I know that 14 states have now passed laws disallowing prior authorization in Medicaid specifically for opioid use disorder medications. And a lot of that activity has happened in the past year alone. I'm particularly interested in looking at some of the language around those laws and if and how they apply to MCO plans as well. So that concludes my talk, and I appreciate the opportunity to share some of our work with all of you and look forward to any questions you might have.
So thank you, that was great. There's some questions that showed up in the chat, and I'll start with those. So Ashley DeGarmo asks, I'm sorry if I mispronounced your last name. Hi, apologies if you mentioned this. However, if the services are not covered by managed care organizations, are they covered by another organization that accepts Medicaid funds like a BHASO?
If the particular